just provide a little bit of discussion points after the two presentations you heard. And I just want to start by saying that the Compass team of investigators and staff are just the most amazing team that I've ever worked with. And what everyone has brought to the trial is all just really making, synergized to make it really what you saw, which is just an incredible product after an incredible amount of passionate focus and hard work. So I'm just going to try to give you the stroke specialist perspective. And unfortunately, I am in my office and there is a helicopter coming behind me, so I hope that that's not going to be too noisy. But the stroke specialist perspective is that, the health systems that we had more difficulty engaging, and Sabina addressed this, the health systems in terms of a stroke center and system of care perspective were all focused, or a lot of them were focused on pre-hospital and acute care. And this was the time when we had just kind of shifted to treating acute stroke patients with interventions. And we're really trying to figure out, how do we triage these patients? How do we decide who gets transferred where? How do we incorporate telestroke into all of that? And so I think that a lot of hospitals just really kind of waved a white flag and said, no, we're not going to worry too much about post-acute care. We want to focus on the pre-hospital and acute care and interventions. So I think that that was actually a factor for participation in at least several hospitals that we tried to get involved in Compass. And then the other thing that's really evolved over my career is that we've got neurohospitalists now. So you have stroke specialists whose main interest is in taking care of sick acute stroke patients. They really don't get as much satisfaction apparently out of seeing patients in clinic, although I would argue that seeing the continuum is by far the most gratifying part of my career as a stroke physician. And so, the other thing is that you get a lot more RVUs for taking care of patients in the hospital than you do for taking care of patients in the clinic. And so that's another kind of barrier to, and that's a system barrier that unfortunately is really hampering the ability to get engaged providers taking care of patients in the post-acute setting. Now, a lot of stroke specialists also believe that primary care should be doing all of this. And I agree that there is much that we can hand off to primary care in terms of prevention and lifestyle. But there are certain aspects of the stroke evaluation that really don't finish until they're seen back in the clinic. And that is not something that most primary care physicians are comfortable with. And in fact, many of them don't feel comfortable managing blood pressure immediately after a stroke and when they're coming back to the clinic. So it is really something that needs to be coordinated. And I think that the other major feature of the Compass kind of implementation, and Sabina sort of got at this a little bit, is that we developed and tested this in a stroke clinic. And this is an academic setting with the neurology hospital floor and stroke floor and ICU are not that far away from our clinic. And we have a lot of overlap in our team members and a lot of interest in both settings. And so, Compass was not that difficult to implement here, but it certainly is more difficult to implement if you've got, physical distance between the clinics and the hospitals, and you've got an entirely different team taking care of patients in both settings. So that's another really big challenge. We're trying to make this integrated, coordinated care model in an unintegrated setting, often across these health systems. And then the other thing I think that Dr. Duncan addressed was the care model and the fact that it was done in a research format, and that actually required some of the providers to have to duplicate some of their documentation. Yes, it's great to have the care plan, but it wasn't something that they could just use as a replacement for their note in Epic or whatever electronic health record they're using. And then another really major gap, and we talked about the fact that we had primary care stakeholders involved, but we didn't really have a lot of space to really emphasize the handoffs between primary care and the stroke team. And so this is something that I really think we're going to be studying in the future. It's a really important aspect of the stroke system of care. It's part of sustainability. You are not going to necessarily have a stroke neurologist or a advanced practice provider, nurse practitioner, PA, taking care of these patients every month for years after the stroke. That's just not realistic. So there does need to be some coordination with primary care and some really clear direction about what the patient is going to need. And then the last point I'll make is that we had, claims data showing us who got readmitted within 30 days, 90 days, 1 year, and who was seen in the ambulatory care setting, but we lacked the ability to actually know what specialist and in what location the patient was seen. And so we don't know from our claims data that it was an APP that was actually in a stroke or a neurology clinic. And so that is a really unfortunate linkage that we weren't able to make based on the claims data. We still know who was seen, and we know if they were seen by an APP or a neurologist, but we can't really identify the training that the APP got. Were they trained to be seeing stroke patients, et cetera. So this is a detail that we would love to flesh out if we could, if we had the data to do so. But those are just some of the additional points that I had, and it's really wonderful to see such a large group of folks from the rehab setting who are interested in post-acute care for stroke and the COMPASS model. So thank you all for joining, and happy to take some questions along with Dr. Duncan and Dr. Gazelle.